So CROI 2022 had a lot of science come out, and for a lot of us who weren't able to go, we're hoping that you, as our 4 experts, will be able to give us some information. And I wanted to start off with the question of what cure-related science did you think was the most important or the most interesting, and why do you think that is in terms of how it relates to the cure? And so I just wanted to give you each a chance to introduce yourselves at first and then answer that first question for us. So why don't we start with you, Deborah?
Yes, I'm Deborah Persaud. I'm a pediatric infectious disease specialist at Johns Hopkins University. I lead the HIV Cure Committee for the NIH-sponsored Clinical Trials Network, IMPACT, and also the PI for the newly funded PAVE Martin Delaney Collaboratory. So do you want me to answer your question, or will everyone be introduced and then we answer the question?
Let's go for it. You can introduce yourself as you provide a response to the question, please.
Okay, so I think the question that Michael asked was emerging science from CROI, and boy, there's a lot of emerging science from CROI, but obviously I'm going to talk with a lens from a pediatrician's side aspect of this. And I think the emerging data on very early treatment in infants, as Thumbi discussed in the FRESH cohort, very early treatment is a unique opportunity to alter viral reservoirs and perhaps enable remission through immunotherapeutics. And so very early treatment has been a major focus at CROI this year, and we presented on our clinical trials that was a follow-up on the case of the Mississippi baby. For those of you who don't know, that was the first case of perinatal infection where we identified very early treatment within the first actually 30 hours of life that led to remission of 27 months. Second is the rapidly evolving space of broadly neutralizing antibodies. And so there were data presented from Roger Shapiro from the Botswana very early treatment cohort where infants received combination broadly neutralizing antibodies, VRC01 and LS and 101074, where he showed and this was really a strategy for safety, but also PK pharmacokinetics data, and also as an alternate treatment to ARVs. And so in that study, 44% of 25 infants maintained suppression for 24 weeks with, albeit weekly infusions of 2 broadly neutralizing antibodies, but 56% did rebound in that treatment switch phase. And then secondly, I think I'm here to present on the IMPACT study P1107, where we used cord blood transplantation, that's CCR5 delta 32, to examine its potential remission in a woman and a woman of mixed race.
Yes, and that was probably the biggest news related to cure that I know coming out of 2022 with that. And it's interesting that that came through IMPACT. I love that IMPACT has been sort of really putting its efforts towards this. And there was a lot of feedback, I think, from CROI this year in terms of the news that came out. There was also the attempt of creating a cohort that was like the Mississippi baby. In other words, there were babies that were caught very early and treated and trying to get them to mirror the sort of profile of the Mississippi baby so that they then may be able to be tested to go into a post-treatment control, perhaps. Is that, could you speak a little bit towards that?
Yeah, so we presented on IMPACT P1115, which is our first very early treatment trial. As most of you know, new infections continue in children. There are about 150,000 new infections each year. A major risk factor is really women who do not know that they're infected during pregnancy. So they're identified during labor and delivery as being infected. And so as part of this trial, our very early treatment strategy is to identify high-risk infants, so infants whose moms did not receive therapy or are not suppressed, and start them empirically, so preemptively on a 3-drug regimen that's minimal. It's all we had at the time. It's ACT, 3TC, nevirapine. At about 2 weeks of age, infants qualify for receiving protease inhibitor-based therapy with Kaletra or lopinavir ritonavir. There is a black box warning to using lopinavir ritonavir in the first 2 weeks of life due to the high alcohol content that's used in that drug. And so all we had for this trial was AZT3TC nevirapine. When age appropriate, infants were lopinavir ritonavir was added to the regimen. And so this trial was actually conducted in 30 clinical trial sites in 11 countries. Nearly 90% of the mother-infant pairs were enrolled in sub-Saharan Africa. A few were from Brazil. And in this trial, we enrolled and followed 54 infants. And what we reported on is a 2-year potential for being evaluated for remission, where these infants will go off antiretroviral treatment. The estimated eligibility for a cohort by the end of by 2 years of age was estimated about 30% of infants. What that means is they test negative for HIV antibody. We know they're infected because they were diagnosed with HIV infection. And second, having undetectable proviral DNA to less than 4 copies per million. That art cessation part of the study was delayed because of COVID. But now that COVID has waned somewhat, we're in the process of beginning evaluation for art cessation.
That's exciting to hear. So I'd like to move to Lish, if you would like to unmute yourself and tell us what you think, in your opinion, was the most important or most interesting cure-related science that you experienced at CROI 2022.
Yeah, no, thank you, Michael. And it's a pleasure to be here and to contribute to this workshop. I just wanted to say it's a pity we didn't have a chance to all meet in person. Hopefully the next CROI we'll have a chance to be together. So I'm Lish Ndhlovu. I'm a professor at Weill Cornell in the Department of Medicine and Infectious Disease, and also a principal investigator on the HOPE HIV Cure Collaboratory. Our interest in trying to find an alternative approach to cure, focusing on sort of a block and lock and excise process. I think this year's CROI was really exciting. I think building on some of the work that was presented today, I thought the recent cord blood transplant case was particularly interesting. You know, seeing a third case being, it gives us good further insight into how potentially a cure could be adopted. I think what I thought was interesting is, sort of CCR5 is really a key driver within the 3 cases. What I thought was interesting was the data suggesting that individuals' cells were resistant not only to CCR5 tropic viruses, but also CXCR4 tropic viruses. I thought that was quite intriguing as we try to understand better, why these cures work. I mean, the cord blood transplantation case has been tested before. I don't know if you recall, several years ago. So it's nice to see a success with that. So I thought that was interesting. From the romidepsin study, the E-CLEAR study, also a really fascinating data set showing an individual who's been able to hold remission for this long. Hopefully this will go, both the cases will go over for 30 months, and then we may be able to move from remission to cure. I thought interesting again that virus in that individual seems to still retain full competency in infecting other cells. I thought that was also very interesting. So I think the mechanisms by which these unique scenarios may help continue to guide us in cure strategies. So I think really fascinating biology around these recent cases of potential remission.
Yeah, I agree with
Great
you.
points. Yeah, I think there's been a lot of excitement around that case. Can we move over to see what Dr. Montaner thinks? I know you got some good insights, Dr. Montaner. Bring it on.
Oh my God, the expectation.
It's
Anyway,
hot.
my name is Luis Montaner. I'm at the Wistar Institute, and I am also one of the PIs of the Beat HIV Collaboratory. So for me, I mean, there were 3 areas that I thought were really cool for the work we're all doing collectively. And I think we've already touched upon this or on these, perhaps I'm going to repeat, but maybe I'll try to explain why I think it's kind of cool on a different way. So I think that the cure news are really exciting because it opens up, as we all know, to a different demographic. The cure agenda, it excites the imagination, and the hope for many individuals to get access to a cure, I think, got a huge boost out of CROI. And I think that improves our collective effort as a community and as a research effort. And it also highlighted the potential, as already noted, the importance of going after CCR5. Obviously, this participant also had resistance apparently to CXCR4, which is the other receptor, but we have other cases of individuals that were not resistant and they still achieved remission. So we would look to those to say that maybe that wasn't the only reason this case actually worked. So a lot of efforts going after modifications of cells, excising CCR5, that type of approach gets another boost out of these news. And I know that a lot of efforts are underway to promote that research. And I think that this news kind of further supports that that's a really good direction to go. The second thing I thought was really cool is the Marina's summary earlier and already noted about finally, we have some data to link an immune strategy to some chipping away at the reservoir. For all this time, we've been talking about how do we measure impacts on the reservoir? Well, we need to stop treatment because that's the only way that we'll see virus, coming out of everyone. And then later came, well, the HIV DNA is not really that accurate because a lot of it is junk anyway, so we can't see what really matters. Then came the intact proviral DNA assay, and Bob Silicano and the Rockefeller team sort of highlighted new ways to look at that specific 1%, that 1% that matters. And then came the question of, well, now that we have that 1%, can we actually find anything that actually alters that 1%? And then the news out of CROI for the first time showed some initial evidence that we can chip away at that 1%. And I think that, and by measuring, intact provirus after broadly neutralizing antibodies, which are, as everyone knows, broadly neutralizing antibodies can be used in more individuals than the alternative, which is their own antibodies, because they can control many individual viruses across many people. And that makes them potentially a therapeutic. That's why a lot of development trials are using them, because it could be accessed by many. But the cool thing is that this is the first time we see evidence that we can link the broadly neutralizing antibody therapy to some indication of reduction in the intact proviral copy number. And I think that that opens up a window of saying, well, what else can we add onto it? Do we need to treat people longer with BNAbs to see a greater reduction? Can we evidence that not just in the blood, but in tissues, et cetera, et cetera? It gives us a roadmap to go after and have some hope that we can continue to take that down. And the last thing I thought was really cool was that the issue that we now have greater evidence on how this 1% or intact provirus may be behaving in people after long-term antiretroviral therapy. It seems that the individuals that are long-term treated start to kind of homogenize their reservoir to a point that is less diverse than when it started. Now, that means two things. One, that if you have a broad number of proviruses and you add an immunotherapy, you have the hope to see a change in the landscape of the viruses, meaning that you're doing something, not just reducing, but changing the reservoir. And then the second thing it says is that if we had strategies that can target that homogeneous virus in that person, we may have a better approach to cure that individual, because the viruses seem to kind of like want to change themselves to stay long-term in a person in a way that it appears to be more predictable. And I think that is also kind of cool, because it gives us perhaps a way to view how to cure strategy can change the provirus in ways that we know ahead of time, what could happen. So for me, CCR5 and the boost, the BNAbs being a path to cure, and the provirus showing itself more clearly as to what happens after long-term ART, that we can actually go after it. And so those were the three things I would say were in my list.
Super cool. Thanks, Dr. Montaner. Dr. Bar, did you want to close us out before we have an enticing discussion about terminology 2.0?
Sure. My name's Katie Bar. I'm at the University of Pennsylvania, just across the street from where Luis lives at the Wistar. I feel that it's very challenging to go after these three commentators on three experts on what was interesting in cure research, and I don't have a whole lot of completely new things to say, but I guess very quickly, the spin I would take on the exciting research from cure are that two things. I think it built on recent explorations, and Luis mentioned this, but there have been studies in the past couple of years using the intact proviral DNA assay on cohorts of individuals treated with antiretrovirals for a long period of time that have shown these levels go down more than we had previously thought. So suggesting there's ongoing immune activity or immune clearance of reservoirs. And I think that gives us an opportunity to build on that with cure interventions. There's also a lot of work in single cell approaches to characterizing reservoir cells. And in particular, Matthias Lichterfeld and Shu Yu, their groups have done these amazing studies pairing single cell analysis of what type of reservoir cell and what type of provirus, but they've largely done that in elite controllers, people whose immune systems are really elite at controlling that virus. But what was presented at CROI were similar studies, as Luis mentioned, of people who theoretically had more normal approaches to the virus, were on antiretrovirals for years and years. And what we can see in those people is that there's also evidence of continued immune pressure on those reservoirs. And I think that is another bit of encouraging news that the baseline immune system is doing some things correctly. And with immunotherapy or other approaches, we can push the immune system to even be better at clearing that reservoir, at suppressing that reservoir. And so that seems like a tangible place that we can make a broadly.
Uh-oh. Everyone's frozen.
With all sorts of different approaches. But in HIV, we've seen antibodies can suppress virus and they can prevent, but we actually haven't seen empiric evidence in human studies that antibodies have the hypothetical immune benefits or reservoir reduction benefits that we are all hoping for. But at CROI, we saw a couple examples of that. So Marina presented both of these, but in studies that she led looking at either viremic individuals or people on antiretrovirals, they saw detectable but small decreases in the reservoir just from receiving antibodies. And then, in my opinion, one of the most important studies from CROI, this eClear study from Aarhus University, where they gave antibodies plus or minus romidepsin, this LRA, to people starting antiretrovirals fairly early in some cases, and then a little bit later. But they really saw what we were hoping from antibodies in terms of an ability to theoretically target the reservoir and lead to lower levels, and in the ability to enhance CD8 T cell responses. So, the promise of BNAbs for cure is not just in their antiviral ability, but it's in the other things that they can do in other contexts. And this has been shown in cancer, it's been shown in other approaches, but in HIV, to show that we can enhance immune responses and chip away at virus-infected cells with antibodies, in my opinion, is really exciting. Now, I'll just say, I think the eClear study is going to lead to, excitement, but so many more questions about what parts of that study were key to seeing those positive effects. Do you have to treat people at the time of ART initiation? Do you have to treat people with earlier ART initiation? What type of sensitivity or relationship to the antibody and the virus do we need to see the various effects? How substantial are these effects with various types of antibody dosing or pairing with other immune therapies? So I think this is a super exciting finding, and the field can build on this with lots of different sort of basic science and clinical trials to try to figure out how we use antibodies which are safe and well tolerated and continuing to be developed so that we can have antibodies available for all virus clades and all virus sensitivities, continue to have delivery systems that make them broadly available to people throughout the world. But how do we fine tune their use, and how do we pair them in order to continue to see virus suppression and virus clearance? I said I would be short, and then I wasn't at all. So
that's
apologies.
okay, though.
That's okay. We love it. We love it. Lots of questions in the chat. So we'll start with a question that Jess from AVAC posted. Often, like, so in recent events, we've heard folks use the terminology, we have 3 individuals cured of HIV. Why not count the other 2 folks whose immune systems cleared HIV naturally in that conversation to increase the number to say 5 versus 3 or 6? What are your all's thoughts?
I personally think we should. I think that we kind of focus on that narrow definition of that stem cell transplant mediated cure. But I think that these examples of natural immune clearance, if they meet the same, they're equally exciting. They are unique instances that are not, again, broadly applicable, but they give us so much information to learn from how this can happen and how we can learn from that. I would also include that, post-treatment controllers, post-intervention controllers who maintain suppression after years off therapy, those individuals are just as valuable in terms of what we define HIV remission or ART-free suppression, and how we learn to make these approaches more broadly applicable. So I think this 3 is really maybe an unfair number. It's 3 of this specific type, and there's many other different approaches that have and situations that have led to this similar endpoint, and we can learn from all of them.
And I just see that Deborah put in the 2 adolescent and 2 pediatric cases that can also be considered post-treatment controllers. So there's a lot.
Closer to 10.
Yeah, we have a lot there. And just in case you all were talking about, the Dusseldorf patient came up, and I at least threw in the PDF of the poster that originally announced that case. It seems like that case is always sort of forgotten about in the hubbub of just trying to talk about the handfuls of people that we know. So did anyone else want to reply to that question that was brought up?
Great response, thank you.
If not, there's another question, and it's sort of related. Moses was asking about, how long does one have to be undetectable off of therapy before we consider them to be cured? Do we have any sort of agreed timeline yet? I mean, that would help us define that. Is there any sort of consensus? And this is for any of you.
Yeah, I think obviously we've been thinking about this a lot when you declare someone cured, and obviously I've been burnt by the Mississippi baby. I didn't say cured, I said functionally cured, and so a little media shy about this. But I was asked, was this possibly, potentially, or likely? And we are so this participant was transplanted for 37 months. Post-transplant when she went off treatment, and then had 14 months of aviremia of treatment. And so the question is, when do you start the clock? When do you start counting the clock? And so actually what we've, in Ravi's paper on the London patient where they declared cure at 30 months, he did some mathematical modeling based on reservoir size to sort of estimate a likelihood of cure. And I think based on that is how he decided at 30 months that this person was cured. And so Alison Hill was the mathematical modeler who did those estimates. So we're actually asking her to kind of come up with some estimates around that. I'm not sure how to come up with a number. I'll just say that 14 weeks post ART interruption, we did detect DNA in this participant, single copy level of DNA. And so that suggests to me that there's still infected cells, and to make the point that Louis and Lish made, really having target cells that are resistant through CCR5 delta 32 is probably what really helps with any traces of perhaps replication competent virus that might still be there. So I'm a little reluctant to come up with a time frame still detecting DNA into her course. And obviously the risk, the most important thing, we've had remission from 2 diseases here, right? She had acute myeloid leukemia and she has HIV. And so both of those diseases are in remission, which I think this case is seminal in that it replicates, the CCR5 delta 32 and its role. But I think it really, in my mind, if we keep adding up cases, it becomes a central case for us to really think about when persons with HIV have an underlying condition requiring transplantation, how much effort should be paid to finding a CCR5 delta 32. And personally, I think this case highlights that in a racially diverse population, there can be, with cord blood cells, access because you need less of a match with the cord blood cells. And so we need to think about moving forward for persons living in settings where, transplants are available, that we should try to see. I'm not a transplant person, but we should try to make every effort to find a match with CCR5 delta 32 to induce remission of 2 diseases.
I agree.
Thanks for that.
Yeah, and also,
Go ahead, Michael.
I was just going to say that I know oftentimes in community when we're talking about this idea of like how long does it take until a remission could be considered a cure, it's an easy fallback to go to cancer. And they've summarized in cancer that if people are in remission for 5 years, they can be considered cured. Although I like to complicate that a little bit because our dear friend who's passed, Timothy Ray Brown, he did achieve a cure for his HIV, but his leukemia did eventually come back to end his life. And so even when cancer says remission is a cure, there's always that chance that something's going to come back. And so there's never a definite answer for people to really rest on that. Hey, it would be great if the world worked that way, that we could say, if you make it to 5 years, you're cured, no problem. But it's not as simple as that. And I think everyone should have an appreciation for those subtleties. And I hope you don't think that we were trying to put you in a corner of saying a time.
We were not.
It's an important question and important for the participant, right? I mean, I think, this is an individual we're dealing with. And
right.
I want you just really highlight her care team at Weill Cornell, Dr. Cohen Bambison and Jingmei Su that took on this approach with the participant to go this route.
And Jessica, I saw you had your hand raised. Go ahead, Luis. I mean, Jessica too.
And then Jess.
I guess, this issue of defining what's a cure, what is an acceptable outcome without antiretroviral therapy goes back to the comments that were made earlier of what do we mean by a strategy that could benefit the individual, in what setting and for what purpose. Because for one particular community, not being on antiretroviral therapy may be a really advantageous sort of position to be in. Whereas in another community, that may not be as a bigger driver as stigma or other reasons that they want to achieve a cure and overcome a diagnosis for as a person living with HIV. So I think that when we think about what is our ultimate objective, I think we need to keep in mind the diversity of kind of like what everyone wants to get out of a cure. Because, for example, we talk about remission as one of the objectives, and this means that we're hoping to get control while the HIV is still present. Now we have data from our colleagues in California with Stephen Deeks and others that have actually also suggested that individuals that are elite controllers may still have a potential benefit for antiretroviral therapy. So we have to then present ourselves with, are we trying to make options available that may be, attractive for different types of individuals worldwide? And it's not a one size fits all, that the only thing we need to achieve is eradication, or the only thing we need to achieve is remission. So I think that it's really hard to kind of have one answer to your question of how do we define how long until we call somebody cured.
It's definitely an ongoing conversation. I know there have been things coming up in the chat. We've been having conversations, and we will continue to have conversations with community. You'll be able to join those where we talk about these words that we use, everything from how you define a cure, how you also can refer to cures, and the terminology that we use towards that. I put in the chat earlier, if you didn't see it, we had a great conversation starter at the last session, the last one, where we were discussing some of this terminology, but nothing has been identified or solidified. Just really having your voice add to the conversation helps us better distill an end result. And as we go through this together, I think we'll get to that final answer. So there were lots of questions still, but one of the things that I wanted to see if I could get from you all, I love how the little pieces of science that come up in the poster sessions are really of interest to me, because that's, for instance, how Timothy Ray Brown's cure was first announced to us. It was a very plain looking poster that you wouldn't, if you were walking by and didn't understand what it was saying, you could have just walked it by and not paid attention to it. And you could even see the Dusseldorf patient's poster. So I didn't know if you had any posters that you noticed that you might want to bring to our attention, or that you thought were curious, interesting, unique, whatever. And I wanted to see what you could tell us about the posters that we can then go back and look at it for ourselves.
I can start. I think
Sure.
most of you probably don't look at the pediatric session, but there's actually a lot on very early treatment in infants. And I think we can learn a lot from, you know, as Katie was saying, in terms of turnover of intact proviruses, you know, really suggestive of how active the proviruses are in early parts of infection in infants. And, you know, really this window of opportunity, you know, as the ear-clear trial is suggesting, that, you know, we really could consider targeting our strategies at the outset with very early treatment to try to facilitate clearance of these intact proviral reservoirs to kind of prevent them from getting to a proliferative state. So there's a lot of information in the pediatric session on very early treatment, intact proviruses, the effects of NK cell mediated activity in clearing from Matthias Lichterfeld's group. And just in terms of even treatment failure, I mean, a sobering number for us for our cure agenda is only 40% of kids globally are suppressed on antiretroviral treatment. So we have a lot of treatment failure. Our regimens are minimal, they're less potent. And so the need for remission agenda, I will say, is really a high priority here. And understanding the biology, which I think has been facilitated by the name Cure Agenda for Pediatrics, has really improved our concepts of therapeutics for treatment for children globally, which is about 1.8 million or 1.7 million children under age 15.
Thank you for that. How about Lish? Do you have anything that was sort of?
Yeah, I think you know, there are a number of really exciting posters. I think Katharine talked about a lot of work on single cell studies, and that got me thinking about Timothy Brown's contribution, really allowing us to look into tissues. I think he provided an opportunity to look across the body, including the central nervous system. He provided a brain biopsy, and I think there are a number of posters that are sort of developing better tools to better understand the reservoir in tissues. And I think that's something that we need to think about as well as we try to help define you know, remission and how long that period is, really, you know, taking advantage of better tools to define the reservoir and persistence in these sanctuary sites. So I thought that was some interesting posters in that area.
Great. How about Katie? Did you notice any?
Yeah, so I mean, I think I have the fortunate opportunity to be on the scientific program committee, so I get to review a lot of the posters that come through, and I'm always just kind of overwhelmed with the high quality of cure research. There are so many excellent scientists approaching this, and there's never enough space to present all of their work. With that being said, as Lish said, there are a lot of new assays in development, and some of these are really complex. Like, I can barely wrap my head around what they're proposing to do, but a lot of these are single cell assays that are pairing very unique ways of measuring different parts of the virus, the provirus, with different properties of the cell. And as Lish said, this could be applied to tissue cells, but also characterizing the phenotype of the cells, the function of the cells, the homing, you know, whether these cells are programmed to go to the tissues or to stay in the periphery. And so putting all these things together, it's kind of a new wave of being able to really drill down on each of these individual cells and ask, how do they persist How do they survive? What vulnerabilities do they have that we can exploit? So I think that's really exciting. And on the other end, I would love to hear Luis talk a little bit about his clinical trial that had an abstract at CROI, and maybe any other clinical studies that were presented.
A beautiful transition.
In the last 2 minutes that we have, Dr. Montaner.
So I thought the posters related to tissue analysis within compartments was really we're starting to see a lot more of that. And I think that's going to be very useful as we move from blood to tissue and try to understand how best to intercede across what may be a landscape of retention of reservoirs between different compartments. So I think that I'm looking forward to that. Regarding our abstract, we basically did exactly the same study that Marina did with their help, because we replicated their strategy exactly. And except that we added interferon on top of it. We also did sensitivity testing at the beginning, like they did, and also the European study. But for us, everyone is sensitive. So in that regard, we would expect that everyone would have a CD8 type of responsiveness that is benefited by the presence of the antibody. Of course, these are chronically infected people, so they are not the early treated like it was noted earlier. So we have to ask our questions. Are we going to see something like the roadmap, where they gave antibody, but in contrast to the roadmap, we stayed giving antibody like Marina's study after they stopped their antiretroviral therapy, and she already reported a reduction in the reservoir, or at least a signal for that. So now we have our cohort with only sensitive individuals with interferon and with the same two antibodies. We would predict we may hopefully see something similar. So I think our poster described the retention of suppression on ART up to the point of the treatment interruption. And I think that now we're analyzing the post-treatment interruption outcomes. And of 10 people that interrupted, at least 2 of them are post-intervention controllers, which I think is pretty cool. I mean, that's 20%. Mm-hmm. And what I was noticing is that we fail people as soon as they get to above 1,000. And I just noticed in these other studies, they put a line higher than 1,000. So I'm kind of trying to reconcile, wait a minute, how should we be looking? Because if I take that definition, then we may have more than 2 post-intervention controllers. So anyway, I think it's early days. We're finishing the study now, but all the reports we've seen from other studies suggest that we may be able to contribute something by the time we get everyone else. And everyone is contributing, like Marina's helping us with the BNAPs and the reservoir assays. Matthias is getting the post-intervention controllers for landscape. Katie's getting the antibodies for resistance. Axelevi are getting the cells for IPDA. So we're basically, recruiting a team effort here that I think we hopefully will be able to contribute by when we put it all together.
That's very exciting to hear. And I wanted to thank all 4 of you for sharing with us in such a way as you have. We will be wrapping this up. I just wanted to start off and tell everyone that we will be doing the raffle giveaway for the session 2 feedback form. If you want to give us feedback about this session, you will automatically be entered into the raffle. There are 5 $50 Amazon gift cards to be raffled off. So you can be one of the lucky winners if you just submit that. And we have lots of announcements still that I wanted to get through if they're still on the line. If not, we will be taking what's in the chat and sharing with you. If you've registered for this and I have your email, I will be sharing with you the recordings from the sessions, as well as the events that will be announced afterwards. But Linda, I know you had one. You wanted to tell us?
Yes, actually 2 quick ones. While we're talking about things that you're sending out, Corinne and I put together a session about terminology that we presented at the first session. So if you have, and I think that the upshot of that was that there was consensus on sterilization needs to go, but and there was a remission. There was a majority of people that thought we should use that, but that's not the, not, in other words, there wasn't consensus. So if you have any feelings about that, that you want to share with us, because we didn't really have a lot of time to, we had our questions, but we didn't have a lot of time for discussion, please send your comments to Michael. And the other thing that I wanted to announce was that the DARE Cab, in conjunction with RID and probably HOPE, CRISPR, and any other cab other than Martin Laney Collaboratory that wants to participate with us, we're going to do an introduction session to gene therapy that we're probably going to start in March or April. So if you're also interested in joining us for that, that very exciting new cure field, please be in touch with Michael as well. That was it for me. So thank you. And thanks everybody for a great session today.
And Jeff, did you have something to announce?
Yeah, thanks, Michael. I did put them both in the chat.
Great.
But the new RID HIV Collaboratory is going to be, our community advisory board is putting together a community town hall meeting in San Diego on Thursday, April 21st in the evening at the San Diego Library. It's going to be a dual event, both in person there in San Diego and also live streamed on the web through Zoom, Facebook, and YouTube, and I think Twitter. So that's happening, all about the state of cure research and especially the agenda, the research agenda of the new RID HIV Collaboratory. And then later in the year in Palm Springs on October 9th, which is immediately following the West Coast Retrovirus meeting that many of the scientists go to, will be a community cure symposium on HIV research in honor of Timothy Ray Brown. And this will be held every year in Timothy's honor. And our first event will feature his successor, London patient, Adam Castillejo. So I dropped in the website for RID HIV, so please refer to that for more info as things develop. Thank you.
Thanks for that, Jeff.
Yeah, I'll put that in the email as well. Jessica, were you still around? Did you want to hit up your events?
Yeah, so just a couple of things. So next week, EGPATH, in partnership with AVAC for PAVE, is hosting a webinar that's going to be introducing pediatric HIV cure research. So I think a little bit new for everybody, and look for EGPATH and AVAC for more details. In those in New York, we'll be planning a number of pieces with the REACH Collaboratory around this sort of cure in New York with the Well Project and Iris House. More details to follow. And I did put a note in about a newsletter with the Moby group that you can sign up for that goes into more detail on viral diversity, which Marina kind of talked about right in the beginning in plain language. So definitely, and that's a series, so keep your eye on that space. And then in Boston, we'll the I4C group is going to be working with the Fenway Health partners to put on some events there. So just more to stay tuned, and I will forward the email addresses to you, Michael, to share with, or the websites to share with everybody.
Great, and we will definitely get those out to everyone who's registered for today. Is there any other announcements? I don't know if I've hit up everyone.
Yes.
Go ahead, Moses.
Michael. Yes, this is Moses Supercharge. Yeah. Thank you so much for the presentations, dear presenters and organizers. That was so amazing. I want to announce that HCAP, which is HIV Cure Africa Acceleration Partnership, in collaboration with. Sorry?
No, I was excited for your collaboration. Keep going.
I just want to announce the folks that HCAP, which is HIV Cure Africa Acceleration Partnership, in conjunction with AIDS Funds, has plans to create a family of HIV cure advocates in Africa. And the first sessions will kick off in Uganda on the 5th and 7th of April, where we shall be empowering and sitting down with 100 HIV cure advocates to empower them and update them about the ongoing HIV cure research. That's what I wanted to inform you folks. Thank you so much, Michael.
Thank you. Daniela. That's awesome to hear about that work. I love hearing it. Any other last calls for announcements?
Yeah, so Michael, this we usually host the Jonathan Lax Lecture every year as a pivotal piece to our HIV education efforts during June. And this year we're going to host it at 9:30 in the morning. We have invited Mike McCune to give us a cure update. And there's several global groups that have already assigned to this lecture, CanCure, and the African Immunology Society, FAIS, Federation for African Immunology Society. So I think maybe HCAP could join us as well. But the whole point is to bring a global community together around the cure effort again. And we're taking this lecture as another opportunity. That will be in June. So awesome. We would maybe send it out to everyone if they want to participate.
Awesome. And just let me throw into your your bucket there. There's the Global Gene Therapy Initiative, which is working to bring gene therapy specifically to Uganda and India. I think they would also be interested in what you're doing with that. So I'll send you word about that afterwards.
Yeah, because I think we're trying to identify people that are interested globally to make community-based form like you're doing here, but also from a scientific piece. So we're taking this opportunity to try it out to see if we can recruit people together.
Well, I enjoyed it last year, so I'll be looking forward to that this year. Thank you all so much. Any last calls for another announcements?
Let's have a round of applause for Michael's outfit.
Oh, thank you. Yes.
Fabulous.
Once again, happy Mardi Gras to you all. Happy Zero Discrimination Day. Thank you all for joining us. Danielle, once again, it was beautiful to co-host this with you. Thank you all for joining us, and be looking for the email with the links to everything after we sign off today and I get those videos posted. All right. Thank you all very much. Take care.
Thank you.
Thank you. Bye, everyone.
Take care.